Hello everybody and welcome to our Mastermind webinar today. Today our topic is Dementia Prevention in Middle-Aged Adults, Exploring the Role for Primary Care. My name's Jenny Pearson and I'm an Education Officer for the PHN and I sit in the New England area. Before we go any further, I'd like to acknowledge the traditional custodians of the land that we're meeting on today and pay respect to elders past, present and emerging. We have three presenters for you today. Our first presenter is Professor Dimity Pond. Dimity is a general practitioner and an honorary professor in the discipline of general practice for the University of Newcastle. We have Amanda Cross. Amanda is a pharmacist and a research fellow in dementia at the Centre for Medicine Use and Safety at Monash University. And we have Parker McGinn, and he is a general practitioner and a conjoint professor in the discipline of general practice at the University of Newcastle. And I'd like to thank them all very much for giving up their time today. Our first presenter is Dimity, and I'll just bring up your slides. Dimity.
Thank you. Ha. Okay, shall I start?
Yes.
Okay, so well, this is just a heading slide. I'm actually a GP currently in clinical practice as well. For those of you who might be wondering, that honorary professor thing looks a bit remote from being in general practice, but not the case. I'm still doing 2 days a week in general practice. Okay, next, thanks. Okay, so why focus on dementia prevention? So most of you might not have had a huge amount of contact with dementia or not be aware of it. But in fact, there are about 50 million people living with dementia worldwide, and that number is increasing rapidly and looking to go to 152 million by 2050. And it costs, this disease costs the world economy a huge amount of money. And we're looking at $1 trillion US there. That's from the Lancet in 2020, which I'll be referring to a few times during this talk. In Australia at the moment, there's been a new report from the Australian Institute for Health and Welfare, which puts the number between the high 300s and the high 400s. And it's tricky, actually, to identify dementia. We know that we don't do a great job of identifying it, particularly in the early stages. And we do expect that number to double in Australia by 2058. So then we'll be looking at close to 1 million people with dementia in 2058. It's the second leading cause of death in Australia in 2019, and in fact, the leading cause of death for women, because women are more likely to have dementia than men, and that's independent of the fact that they live longer. And it cost the Australian economy $3 billion just in the 2018-19 year. So it's a very expensive disease in Australia as well. And if we can prevent it or even slow it down, that would, you know, there's a sound economic argument for doing that. And it would also cause, you know, reduce the suffering and the stress, both for the person with dementia and their family members as well. Okay, we'll have the next slide, thanks. So I just thought to focus the mind, we might think about a case, and this is Jan Brown, who's 45. And she comes to see you, the GP, for a checkup, or it could be you, the practice nurse. Because in fact you can do a preventive health check at 45. She hasn't seen you before. She's a new patient. And she says that she's particularly worried about dementia because her mum had it. And she thinks she might be more prone to it because of that. And she remembers that it was particularly traumatic for all the family, for her mum and the whole family, when her mum had dementia. And dementia does last for roughly 10 years from diagnosis. It's a terminal illness, so to death. That time it can be shorter or a lot longer. And it causes, as I said, stress, anxiety, depression. It's a very sad disease. So Jan had heard that there was something you could do to prevent it, and she wants to know, as I'm now 45, I'm middle-aged, is there something I should be doing now to perhaps either not get it or, delay it as much as possible? So I'm interested in you putting in the chat, what would you advise her? Have you guys got any thoughts about what you could do to prevent dementia? There's a chat and you can type the message there. Are you getting any feedback from people? Yeah.
Not yet.
Any ideas, guys? Or you really don't know what what you could do at the age of 45? It sounds as though you don't know. Very interesting. Okay. Well, I think this project is very much needed in that case. All right. Either that or you can't find the chat, or a mixture. But I'm assuming that really you haven't got a huge number of ideas about what you could be advising Jan. All right, we'll move on to the next slide. Let's have a look at what might be done. So this is a slide from that Lancet article that I mentioned, which the reference is on slide 2. And you can see that there's a number of risk factors there. And I hope you can see this relatively clearly from your computers, wherever you are. But there are actually 12 risk factors in this slide that can be modified. And they start with early life, and that's to do with education, because a better education is protective against dementia. And they talk about brain reserve. And then they move on to midlife, which is our patient Jan. And here they talk about hearing loss, traumatic brain injury, hypertension, which we are all aware of patients with hypertension, alcohol, more than 21 units per week, standard drinks per week, and obesity. And you can see that the risk is written in numbers beside there. So for hearing loss, there's 1.9 times the risk of having dementia as a person without hearing loss. So that's quite significant, almost twice the risk from having hearing loss. There's still argument about the hearing loss. And for those of you that are interested, there has been some work done which shows that correcting that may actually reduce the risk of dementia. There's been longitudinal studies now looking at a decade at least, and that's what they found. So we'll have a little bit of a talk about some of the others as we go through. And there's a whole lot of later life ones too. And looking at those later life ones, you might think that there are things you could do to stop those being there in later life. You could do those in midlife. So we'll move on to the next slide. Okay, so why bother? Well, first of all, it might work, and we've had a look at that Lancet article, which shows that these risk factors are very real, measurable, and do increase the risk of dementia. Secondly, you can divide the risk factors into non-modifiable ones, which weren't on that slide, like genetics. And there's only a very slightly increased risk for Jan with her mother having had dementia, unless, you know, there were multiple other relatives with dementia, in which case it might be a risk, quite a significant genetic risk factor. But mostly it's not genetic. Mostly it's due to these modifiable risk factors. And furthermore, addressing these risk factors is useful for people's cardiovascular risk. It's useful for their quality of life. It's useful for preventing diabetes. So it's worth thinking about this in midlife, the 45 to 65 range, and doing something about it before it becomes a real problem. And so, you know, we as GPs or nurses in primary care are in an ideal position to give advice about lifestyle changes, avoiding environmental hazards like smoking, and pollution was one of the later ones too, and of course medication for some of those risk factors that are responsive to medication. And middle age is a critical period for these. There's still work being done on the prevention. As you can understand, looking at prevention is tricky because it requires such long-term follow-up. And the people speaking later will explain how this project is going to look at the effects of involvement in this project on prevention of dementia. Okay, we might have the next one. Okay, there, as I said, there is an MBS item. So this is a health assessment item number. You use it for the 75 plus health assessment, but there's a health assessment available between 45 and 49. You won't, I'm not quite sure. I am on the project advisory group, but I'm not sure that they're going to use that item number in the project, but it might be for the people in that age group. But you need to know that you can do this well beyond the project. So I have patients in the 45 to 49 year age group that I've asked. I have a little advisory group of patients, and I've asked them, did you know that we could do a health assessment on you at that age? And one of them was very angry and said, really? I'm 49 now. I'm going to turn 50, you know, in a couple of months. I'd better go and get myself assessed. Please, why don't you tell us more? So we're not good at doing the 45 to 49-year-old health assessment in Australia. Only about 6% of eligible people get it. Much better at doing the 75 plus. That's more like 50%. So it involves information collection, an overall assessment, and then interventions. And you need to record it as you do for the 75 plus and give a copy to the patient or the patient's carer if that's more appropriate. Okay, we'll move on. Okay, so thinking about what information you would collect and a little bit about what you might do. So we noted that hypertension was one of the risk factors, and the Lancet talks about a systolic of greater than 140. And I believe the project has a diastolic measure as well. And that it's 1.6 times greater rate of dementia in later life if you have this systolic greater than 140 in mid-age. And any of you that are in the audience in mid-age might like to think about that, because there's heaps of people with a systolic greater than 140 amongst my patient cohort, and they kind of don't really want to take tablets, and they kind of don't get around to doing the exercise and diet stuff. And if I mention dementia to them, that is a very, very motivating thing for having them address their lifestyle factors or take medication. And there is evidence that the medication reduces the risk of dementia in later life. The medication obviously reduces the hypertension if it's an antihypertensive medication, but it also does reduce the risk of dementia in later life. High cholesterol, atrial fibrillation, stroke, they all increase the risk of dementia, and we need to use standard treatments. And of course, atrial fibrillation is one that gets missed a bit in our practices, since we're no longer listening to people's hearts or measuring their blood pressure in using the auscultatory method. So I think the newer automatic sphygmo machines will tell you if the pulse is irregular, but not all of them do that. So it's worth just checking someone's pulse every now and then. Diabetes is an increased risk, and we don't know with diabetes whether intensive control or any particular medication reduces the risk. So there's just not the evidence out there yet, because, as I said, these are very expensive longitudinal studies that need to be conducted. Okay, we might look at the next one. Okay, so then moving on to alcohol, I mentioned the 21 standard drinks per week increases the risk, and you should reduce alcohol consumption to less than this. And I think I didn't actually find a reference that said that indicated that reducing that reduces dementia. So I can't answer that question. But of course, we need to reduce it anyway, because that's above the recommended guidelines. Smoking at any age increases the risk 1.6 times. So on the Lancet slide, smoking was in the late life section, something you need to address. It's been proven to be associated with dementia in late life. They haven't yet, and they haven't yet shown what reducing it in midlife does in terms of dementia. But in late life, ceasing smoking for more than 4 years reduces the risk of dementia. So anyway, for all the reasons that we are so well aware of, people need to be advised to stop smoking. Obesity. So in the Lancet, we're looking at a BMI of greater than 30 and not less than 30. 25 to 29 isn't associated with an increased risk, but greater than 30 is associated with a 1.3 times rate of dementia in later life. And all you need to do is reduce your weight by 2 kilos, which I happen to have done since I retired, and I've got more time to walk. And that can improve your attention and your memory. So isn't that wonderful? I'm just waiting for that to happen at the moment, but hopefully it will soon. The long-term data is lacking for that, as with many of the other things. And physical inactivity, the Lancet says it's a 1.4 times greater risk of dementia in later life. So there's varying amounts of exercise recommended. And I've just put in this Australian reference, but you'll need to, if you're part of the study, you'll need to see what the study guidelines recommend. But the Australian reference, for people who have already got some subjective memory complaints or, in fact, mild cognitive impairment, suggests 150 minutes of moderate intensity exercise per week, which could be a brisk walk, and progressive resistance training 2 days a week, and some balance training. And all of them should be individually tailored. So you, the GP or practice nurse, might be able to recommend a gradually increasing dose of exercise. And it's so easy, guys. Why don't people do exercise and diet? I just don't know. Traumatic brain injury, 1.8 times increased risk. So maybe that's more of a policy issue. Or maybe, it's a question of making sure that people who are riding bikes during lockdown make sure they wear their helmets. Some of them don't, I've noticed. So there's things we can do as GPs, even for that, to try and prevent the risk. Okay, next slide. Okay, so there's other risk factors, and the involvement in the study will give you some information about those. But certain sorts of diet, I think the study's using the Mind diet. Other people use a Mediterranean diet, are protective against dementia. So plenty of fresh fruit and vegetables and some olive oil. But fish is very good. So if you're involved in the study, you'll get some intensive training in this. Depression, that's a risk factor for dementia, and we really do need to treat it. And it may well present in mid-age, particularly during the pandemic. So you're probably all very well aware of that. So your local resources for depression, for mental health, need to come into play there. Social isolation, I've put a nice slide there of 2 people talking to each other without masks. I couldn't resist it. Well, hopefully soon. And lack of cognitive stimulation. So really sitting on the couch watching Netflix all day during lockdown. I think in Sydney we're up to the 15th week. I might be wrong. Might be 16th week. That's not going to do it. You need to actually engage the brain a bit more than that. So you could be telling your patients this. Next. So there's another lovely picture. They're older people rather than mid-aged people, but look as though they're having fun. So, and this project's called Happy Mind. So we're hoping to make the minds happy and the people happy. So you need to look at the other uses for the risk factors are to identify them for preventive advice, and also identify them because you might want to use those to target cognitive function tests. So in general practice, at the 75+ health assessment, we often do a cognitive function test anyway, but the guidelines actually say only do it for people at risk. You'll get more bang for your buck that way and fewer false positives. So then if you think about all those risk factors, there's quite a lot of people aged 75 and over who have several of those risk factors, and you might be able to even construct a dementia risk score for intensive follow-up for those. And the study will help you with working out how to do that too. So I think that's all. Is that right? Don't have anything else, do I, Jenny? Oh, yes, I've got that. Okay. All right. And I've got a summary slide. That's right, I'd forgotten. So there we are. We've covered less education we haven't covered because that's not a GP mandate. It's probably a policy thing. Hearing loss, traumatic brain injury, hypertension, alcohol and obesity we've mentioned. And then some things that might impact on later life we've talked about, like physical inactivity, diabetes, depression, smoking. The social isolation I didn't go into, but, you know, and obviously that's more going to affect dementia in later life, but It's not good for people in midlife to be socially isolated either. Even Zoom is better than nothing. And air pollution, again, more of an environmental risk factor and more of a policy issue. Okay, and the last slide. Okay, so there are in fact multiple risk factors for dementia. So you might need to think about those. If you're going to start doing 45 to 49 health checks, it might be worth making a list. And as a GP, we can intervene at any stage. We don't have to just be doing it in a 45 to 49 health check. There's a diabetes one that you can do from 40, if person's at risk of diabetes. But you can address these risk factors as you go along in ordinary clinical practice. When you're checking people's blood pressure, making sure you check their pulse, when you're looking at their cholesterol, we all do these things. And adding in that this might reduce your impact, the possibility of you getting dementia is such a powerful motivator for people. And ideally, all of us could do it. It's not just GPs and practice nurses. It's all levels of society, healthcare workers, the community more broadly, making sure that people are not socially isolated, for example, ensuring, local government, ensuring that there's, easily walkable areas for people to exercise, and policymakers looking at how much education people get, looking at air pollution, all of those things. It's a whole of community exercise to address these risk factors. And if we did that, if we actually could do that, ideally, you would be able to reduce the prevalence of dementia by up to 40%. And wouldn't that be a wonderful achievement? Okay, thanks, guys.
Thanks very much, Dimity. I did just have a couple of comments, which I'll just quickly, after you asked that first question, I had, I am a nurse and would advise pathology, MS, MMSE, etc.
Yes, so that would be the cholesterol, for example. Yeah, that's good. Very good. Yeah.
And also, I presume you can also attend a check on 50 to 60-year-olds?
There isn't a Medicare health assessment number for 50 to 60-year-olds. So that nice set-aside payment for a health assessment applies to 45 to 49. Of course, you can attend for a long consultation and get a check, but there's not a specific Medicare number for that.
And there was one more. Do you like to do blood tests with vitamin D, B12, and when do you like to do a CT and at what age?
Okay, so if I think someone's got cognitive impairment or they're worried they might, they've got subjective memory complaints, then I will do a blood test that includes B12 and folate, and I will do a CT scan because we want to make sure that we don't miss a brain tumour, or normal pressure hydrocephalus can cause cognitive impairment. Multiple sclerosis can cause cognitive impairment. It might present like Mayo. So you need to exclude other brain pathology. For diagnosing dementia, I believe there are advanced techniques with MRI that can do that. But of course, we GPs can't order those. So it's really more, the CT is to exclude other causes of those cognitive problems. And the B12 folate, yep, that's quite true. Vitamin D is, it's still being explored, and we did a literature review and published on it a few years ago, and there's mixed evidence, but there isn't sufficient evidence for us to say that a low vitamin D causes dementia at this stage, as far as I know.
I did have one more question just come in. What age would you recommend a health assessment for Aboriginal and Torres Strait Islander patients?
Ah, yes, okay. well, they can have one of those remunerated health assessments from 50, but of course they can also have their 715 health assessment. Now, I don't work in an Aboriginal medical service, but I believe that the 715 health assessment that's specific for Aboriginal people can now be done at any age, even for much younger people. So that would be worth just Googling MBS online and checking. And it's a very worthwhile thing to do. And the pro forma for that really encourages us to explore all the social determinants of health that the Aboriginal community has. So it's really worth doing. And for example, in the Aboriginal community, they've looked at childhood trauma, and you would be familiar with the stolen generations. Childhood trauma gives you a 3.4 times greater risk of getting dementia than a person who was not subjected to trauma as a child. So that's a huge risk factor for Aboriginal people. So it's worth exploring that. We have many stolen generations people. That government policy was still in operation into the 1970s. So we have many children who were taken from their families and put in institutions for government policy, and they're now hitting the sort of age where they might get dementia. So that's, if you have an Aboriginal person, you need to explore whether that's part of their story.
All right, Amanda, are you there?
Yeah.
I'm just going to let you share your screen.
All right. Thanks for having us today, and thanks, Dimity, for setting the sort of background to why dementia prevention in primary care is so important. So I'm here today to talk to you about an opportunity to get involved in a clinical trial that we've got running, and that trial is called the Happy Mind trial. So holistic approach in primary care for preventing memory impairment and dementia. So as Dimity mentioned a couple of times, the basis of this kind of came from the Lancet paper, so the original paper and then the updated version in 2020, which shows that risk factors for dementia occur throughout a person's life, at the lifespan, and the bulk of them start to sort of really hit in midlife. So often when we're thinking about dementia prevention, we're thinking when they're actually starting to get subjective cognitive decline or actual mild cognitive impairment, but there's a lot of evidence emerging that we can tackle this a lot earlier. So the aim of our Happy Mind study is to evaluate the effectiveness of a multi-domain intervention, so our Happy Mind program, for assessing dementia risk and reducing dementia risk factors in middle-aged adults in the primary care setting. So we're conducting a 2-arm cluster randomized control trial. So there'll be 2 interventions, the minimal intervention and then the Happy Mind intervention, and I'll go through those on the next slide. We are recruiting primary care clinics across New South Wales and Victoria, and we're aiming for about 34 clinics at this stage. So we will be recruiting the clinics. They will then get randomized to 1 of 2 interventions, and then the clinic will be responsible for recruiting patients. And we are targeting those sort of middle-aged community dwelling adults with 2 or more modifiable risk factors for dementia. We would prefer people to be existing patients of your clinic, just so that we can continue that rapport that you've already got with the patient. And as part of the intervention is delivered via a smartphone, they do need to be able to own and able to use a smartphone. So in terms of those 2 modifiable risk factors, as Dimity has gone through, that would probably cover most middle-aged adults, to be honest, especially as we're all sort of struggling with various degrees of lockdown. So things like, as she'd mentioned, poor physical activity, poor diet, all the cardiovascular risk factors like high blood pressure, high cholesterol, type 2 diabetes, obesity, as well as moving on to some of those sort of social aspects, so depression and social isolation. We've also got a couple that we're targeting that are not in the Lancet paper, so things like high-risk medication use and sleep apnea. So basically, our intervention will involve sort of a trained practice nurse and the GP team and whoever else is in that person's healthcare team, working to increase protective factors, so physical activity, healthy diet, and cognitive activity, and decrease the prevalence of risk factors. As you can see, we've included both the midlife and later life risk factors, and that's because we're wanting to try and identify those risk factors in later life that may become a problem in terms of their ability to contribute to dementia, and sort of change the behaviours and get those conditions under control before they become a problem. So our two interventions, our minimal intervention, to go through what your clinic will receive first. So we'll be training 1 or 2 practice nurses from your clinic to help them identify risk factors for dementia, and also deliver the cognitive assessment, which forms part of the data collection. The nurses will be responsible for identifying patients, recruiting them, conducting or organising the data collection, and then delivering the intervention. So to help cover that staff time, there is remuneration available of up to $13,500. For the patients, they will receive an individualised dementia risk report. So this is based on their health status and the answers that they provide to the questionnaire, and it will outline exactly which risk factors are present for them to help guide the conversation around risk reduction in an individualised, patient-centred kind of way. They'll receive some education on dementia risk reduction, and the report and the education is then designed to help stimulate that conversation with their GP or their other healthcare team members to help develop their risk reduction plan. Our main intervention, so our Happy Mind intervention, is obviously more intensive. So in terms of the clinic, the practice nurses again will receive a training to identify risk factors for dementia. They'll receive training in how to deliver the Montreal Cognitive Assessment. And they also will attend a 2-day training on motivational interviewing and behaviour change theory. So this is really helping them to develop the skills and the processes to work with that patient to help identify barriers and identify enablers, and really work with them to help implement behaviour change that is necessary to reduce those risk factors. As the Happy Mind intervention is more intensive, the remuneration for the clinic is higher to help cover that additional staff time required. For the patients, again, they receive that individualised dementia risk report and education. But the key parts here is they'll receive 6 sessions with that trained nurse to help identify their risk factors, sit down and talk through them, work out which ones they should focus on or would like to focus on, and prioritize them. As I said, help identify barriers to change, whether that's, they don't know what they're meant to be doing, or whether they can't afford going to the gym, or finding other ways to sort of work out and reduce those risk factors. And then helping them to set SMART goals, so specific, measurable, attainable, realistic, and time-based goals for that dementia risk reduction. And that will be all sort of formulated into a clear action plan, which the nurse and the GP and the other members of their healthcare team will help them implement. Patients in the Happy Mind intervention also receive access to our Happy Mind app, which has been specially designed for this trial in conjunction with the CSIRO. And that is to sort of help them in between those sessions with that trained nurse to monitor how they're going and track their progress against the goals. So we'll have their goals for example, what their blood pressure might be, or what their physical activity targets might be, some of their diet targets, and then they can enter in how they're going, and it will sort of show them happy or sad faces. And the clinic, so your nurse, the trained nurse and the GP, can also monitor that via the clinician portal. Our primary outcome for this study will be the Australian National University Alzheimer's Disease Risk Index score. So this questionnaire scores a patient's dementia risk between -13, which is actually a high prevalence of protective factors, so good behaviours, all the way through to +64, which is the highest prevalence of risk factors for dementia. And obviously in this study, over the first 12 months, we're hoping to reduce that score. And the trial will go for 3 years. So our secondary outcomes will also look at the change in that score at the 24-month and 36-month time point. There are a number of other secondary outcomes which we'll be also evaluating, like things like quality of life, changes in individual risk factors. So looking at whether the intervention is sort of effective for blood pressure or effective for cholesterol lowering or physical activity. And we'll be performing an economic evaluation to assess the cost effectiveness of this sort of intervention as well. In terms of what the next step is for everyone listening today, I believe that you've all been sent or will be about to be sent expression of interest forms. And that will sort of provide a little bit of detail about what the study is and also just some eligibility for different clinics. We're looking for clinics that are accredited practices with a reasonable sort of middle-aged cohort, just to sort of help with recruitment. As we do need clinics who have a practice nurse who's able to sort of participate in the trial and attend the training. And as I mentioned, there is remuneration to help cover that practice nurse's time. And as I mentioned again, it's a 3-year trial, so being committed to completing the full 3 years is important as well. If you have completed the expression of interest, or if you have any other questions, or if you'd like us to give you a call to discuss further, please send us an email at happymind@monash.edu, and one of our team will reach out to you to discuss things further. But to round it back up in terms of sort of the clinical benefits and the practice implications, I'm going to hand over to Parker, who will sort of just briefly discuss what the potential future benefits for general practice will be after this study.
Thanks, Amanda. So the future benefits, I think, is just trying to talk about essentially what happens if the trial works. What happens if the intervention is shown to reduce risk of dementia? What does it mean for general practice? So I think I'd frame this in a concept that one of Dimitri and my former colleagues introduced it to, and it's the aorta syndrome. And aorta be doing that, and aorta be doing this, etc. And that's where we have subspecialist colleagues who will tell GPs that what they ought to be doing based on their narrow understanding of their area. And our colleague used to refer to a paper where someone had calculated how long it would take in a GP's working day if they actually implemented all the recommendations, and there wouldn't be much time left for dealing with symptomatic presentations. So whenever you become involved in a trial, I think you should think about how is this going to work in real life with GPs, and is it worth the candle? So I think Dimity's given a pretty comprehensive case for how important dementia is, how prevalent it is, and the enormous social cost apart from anything else. And I also can't sort of help, again, as Dimity sort of talked about, I've been involved in a trial that finished up recently on secondary prevention in patients who had stroke, and how many of the interventions in the Happy Mind are similar to those in our study of stroke. So obviously there are some dementia-specific interventions, the cognitive activities, etc. But hypertension, diet, exercise, smoking, alcohol, etc. These are common to those stroke prevention, and it will be the same as with other cardiovascular prevention, and even for prevention of a whole lot of cancers. So I think this isn't a case of a narrow recommendation. This is really important general practice topic. So the thing to think about then is, okay, if it's shown to work, will it actually work? Will it work in practice? And that's where I think Happy Mind has been framed in a way that I think will be practical for GPs as part of their everyday practice. So Dimity is referred to being able to, especially being able to use the 45 to 49 health check as a way to organise appropriate remuneration for this activity. And I think also vital is the involvement of the PHNs, because I can see in further rolling out of this model, the PHNs will have a vital role in training and supporting the practice nurses in the delivery and maintaining that delivery by the general practices. So I think if we look to the future, as we always should before becoming involved in a trial, I think we can say if the results warrant it, then this is something that will be practicable for GPs to do and has the potential to make a difference. So thank you.
Thanks everybody very much. Thanks Parker, Amanda and Dimity for your presentations today. If there's any more information that anybody wants, just please email the education team and we can pass on your queries. There will be a survey that will pop up at the end, and if you could just take a few minutes to fill it out. Thank you.
Thank you.